This is our presentation on the rubella virus. We'll start with the microbes characteristics. It's of the genus Rubivirus of the family Tovagrade. It is a spherical single-strand RNA virus with positive sense and spike-like surface projections of hemagglutinin. It has two clinical manifestations, one in adults and children called German 3-day measles, and one in fetuses and pregnant women called congenital rubella syndrome. In adults and children, the transmission is via airborne droplets spread by an infectious person coughing or sneezing. Rubella is usually mild with few noticeable symptoms. 25 to 50% of people are asymptomatic, which is problematic because a person with an active infection can be contagious for up to 7 days before the rash appears and for up to 7 days afterwards. Primary symptoms may occur 1 to 5 days before the rash appears. These symptoms include mild illness, low-grade fever, headache, swollen lymph nodes, and mild pink eye. The distinguishing symptom of rubella in adults and children is an itchy red rash that begins on the face and spreads to the trunk of the body, the rash usually lasting 1 to 3 days. For congenital rubella syndrome, that is when a pregnant woman becomes infected with German 3-day measles, and the virus gets into the placenta and infects the fetus. These complications are serious and can result in deafness, cataracts, heart defects, intellectual disabilities, including autism, liver and spleen damage, low birth weight, skin rash at birth, glaucoma, brain damage, thyroid and hormone problems, and inflammation of the lungs. Pregnancy complications can include miscarriage and stillbirth. Treatment and prevention of this disease. There is no treatment for rubella or CRS. The best way to deal with the symptoms is whatever way your doctor tells you to, and depending on the birth defects, if it's a child with CRS, whatever treatment management is recommended. The MMR vaccine, measles, mumps, rubella vaccine, is highly effective in preventing rubella. Unfortunately, due to various populations not having access to the vaccine and the small populations of people who opt out of the vaccine, the virus can still infect and cause serious health problems for pregnant mothers and their unborn children. Also, if the MMR vaccine is given to a pregnant woman, because it's a live virus vaccine, it can still cause birth defects and complications. So the MMR vaccine is not recommended for pregnant women or for women who intend on getting pregnant within 4 weeks. Going from clinical manifestations back to the replication and mutation of the virus, the rubella virus has a relatively slow replication rate, resulting in an incubation period of 12 to 23 days and a 5 to 7 day delay before the virus spreads from the infection site to other organs. In non-fetal infections, the virus replicates in the upper respiratory and nasopharyngeal lymphoid tissue and eventually progresses to the regional lymph nodes. Fetal infections occur when the virus, which is replicated in the pregnant host, infects the placenta, thus transmitting the virus to the fetus. The rubella virus enters the host cell via endocytosis. When performing replication, the virus uses the mitochondria of the host cell as the machinery to build new viral RNA strands. The rubella virus uses a capsid protein to attach to the cytoplasmic membrane of the host cell. Because the virus is positive sense, its positive strand RNA functions as both its genome and messenger RNA, which cues the host cell ribosomes to synthesize viral proteins for viral replication. There is a large population of RNA viruses that have rapid mutation rates. This is in reference to the mutation of the rubella virus. But the rubella virus, despite being an RNA virus, does not share this trait. One properly administered MMR vaccine is shown on average to be 90% effective against rubella infections. This illustrates the inability of the rubella virus to mutate rapidly or dramatically enough to evade the immunity granted by the vaccine. In order for the rubella virus to mutate enough to evade the vaccine's effects, it would need a simultaneous, massive set of mutations that alter multiple proteins of the viral surface proteins, multiple parts of the viral surface proteins, in order to evade the antibodies that target the virus. Researchers have discovered that even when they induce these mutations in a laboratory setting, the resulting virus is so altered it has lost its ability to bind to the receptors of the host cell and cannot cause disease. When looking at the nutritional effects on replication and mutation and its clinical manifestations, it is well known that malnutrition has an adverse effect on the immune system, and there's plenty of evidence that malnutrition increases the likelihood of rubella infection and the severity of the disease's effects, especially for pregnant women and their infected fetuses. Malnutrition has been shown to decrease effector memory T cell function, which can potentially alter the effectiveness of the MMR vaccine, as well as impair the other immune cells that fight the rubella infection. This makes it easier for the rubella virus to infect and replicate prolifically in its hosts, which in cases of fetal infection can lead to more severe cases of CRS and stillbirths.